Hello again. So this lecture we're going to be talking more specifically about the monoamine hypothesis, which I kind of referred to in the last video, Pharmacology of Depression. So specifically, the monoamine hypothesis states that depression is a result of a functional deficit of the neurotransmitters norepinephrine and serotonin at specific synapses in the central nervous system. So what we're going to look at specifically is the pharmacology of the monoamine hypothesis, as well as what exactly is believed to be happening. One of the very first antidepressants ever was a monoamine oxidase inhibitor, or an MAOI. And this drug was called iproniazid. Which was actually originally made to be an anti-tuberculosis drug. However, it did actually find to have some antidepressant effects. And remember that monoamine oxidase, or MAO, is responsible for helping to clear monoamines such as norepinephrine and serotonin out of the synapse. So it helps clear away excess neurotransmitters. So what MAOIs do is it prevents MAOI from happening so that the neurotransmitters will stay in the synapse longer. So that means that the monoamines they won't be broken down as fast or at all, and it allows them to synapse with the postsynaptic cell more, so you get more of an effect, therefore increasing the effects of these neurotransmitters. So another one of these drugs that was very common, it's no longer in use, but it's called phenelzine. This is another MAOI that was widely used in a clinical setting. It was discontinued because of this thing called the cheese effect. So the cheese effect is kind of fun. What it is it's an acute attack of hypertension. So someone gets hypertension, and this occurs when a person takes an MAOI drug who eats cheese. So it's literally an interaction of the drug and cheese, and it causes hypertension. And so other foods and drinks can also cause this effect, such as some red wines, yeast extracts, some pickled food, but it's most commonly seen with cheese, so that's why we call it the cheese effect. Now, side note, you'll note that I have these two drugs in boldface. While you don't need to know everything about these drugs, I do want you to know that these drugs are MAOIs. Okay? So, in this class, you do need to remember the drugs, but you don't need to know too much about them other than what kind of drug they are, and then what do those types of drugs do. So, MAOIs, I told you about a couple, but this is what they tend to look like in the chemical structure. Again, you don't need to memorize the chemical structures, but you do need to be able to recognize what drugs are MAOIs. So here we have phenelzine, we have tranylysipramine, monoclobamide. Again, you don't have to know how to say them. You don't necessarily have to know how to spell them. I know I probably couldn't, but I do want you to be able to recognize the name and the type of drug. So recognize that these three are MAOIs. So more specifically, what do MAOIs do? So they create an increased presynaptic monoamine level, presumed to lead to enhanced monoamine release. So So because we don't have these MAOs occurring or interacting in the synapse, then there's nothing to tell the presynaptic cell that enough monoamines have been released into the synapse. So the presynaptic cell will continue to release more monoamines as nothing has informed it or triggered that presynaptic cell that there is too much, or that the monoamines are no longer effective. There are different types of MAOs. So there's MAO-A, B. So MAO-A and B are both present in the central nervous system, but MAO-A is also found in the gut. So in the gut, that's where it breaks down tyramine, which is found in food, and then the tyramine can then be shuttled in to the brain and help make more serotonin, as we talked about last class. So MAOIs, such as the ones we talked about previously, phenylzine and that one with a complicated name, will actually inhibit both MAOAs and B. So MAOIs don't really selectively inhibit, they just inhibit all MAOIs. So we talked about tyramine a bit. So tyramine is part of that cheese effect. So it's degraded in the gut by MAOA, as we just talked about. And some tyramine-rich foods, such as cheese and red wine, will lead to the elevations in tyramine in the presence of MAOI drugs. So because MAOA isn't able to break down this tyramine, then we get that buildup of tyramine, which leads to that hypertension we talked about with the cheese effect. So tyramine, what it does is it acts to release norepinephrine from nerve terminals, where it will persist. So this is due to MAO inhibition. And then that elevated norepinephrine symptoms range from headaches to hypertensive crisis, and too much of this can actually be fatal, and that's why some of these MAOIs are no longer in use. So nowadays, MAOIs, they are still on the market, but they do tend to be a last resort drug, so people will tend to take other types of drugs, such as SSRIs, which we'll talk about in a bit, and other types of therapies before they try MAOIs, because they can be very dangerous. So other types of antidepressants other than MAOIs would be tricyclic antidepressants. If you just look at the chemical structures here, you can see they have three, there's three benzene rings, or two benzene rings and another ring. And so they have three of those kind of circular hexagon structures, so that's why they're tricyclic. Again, you should be able to recognize these names. I'm not even going to try to read all of them. Recognize that these four are tricyclic antidepressants. You'll notice that all of them do end in INE, so that might be a little bit of a hint, but don't rely just on that ending. So what are tricyclic antidepressants? Sometimes we'll call them TCAs. So TCAs were developed in the 1950s as well, so it's about the same time as MAOIs. And what they do is they inhibit transporters of norepinephrine and serotonin specifically. So they're specific transporters. So remember, these transporters act similar to GABAs, where their job is to take excess neurotransmitters in the synapse and bring them back into the presynaptic cell to clear out that synaptic cleft. So one that you're going to want to remember is imipramine. That's the name. More commonly, you have tofranil. That's another name for it. But either way, again, recognize the name. Notice how this one, again, ends in I and E. So probably a tricyclic antidepressant. And again, because we're inhibiting these transporters from doing their job, this leads to an elevated amount of norepinephrine and serotonin in the synapse. And this will lead to prolonged and increased postsynaptic activity, which in this hypothesis would lead to then an elevated mood. So there are side effects, just like all drugs. While this one no longer has that cheese effect, it can lead to dry mouth, constipation, and urinary retention. So not the best. And these side effects all kind of act on that muscarinic receptors. So they're anticholinergic. There is a pretty poor safety margin with these, and they can actually induce mania at higher doses. So you really have to be careful with the dosage of this type of drug. Now, a third type that we're going to talk about are probably the most widely used ones today. So these are selective reuptake inhibitors, commonly referred to as SSRIs or SNRIs. These ones are, again, more popularly used nowadays. So we've got fluoxetine. So fluoxetine is actually what Prozac is. So again, that's a very popular one. There's another one, it's not on the slide, but Lovox is another SSRI. Celexa an SSRI. So Celexa is actually, that's what this one is, the citalopram. So these are the ones you hear about more often nowadays. So these are a targeted drug design. They're a second generation antidepressant. So SSRIs are selective serotonin reuptake inhibitors. SNRI is serotonin norepinephrine reuptake inhibitors. So based on the names, you can kind of understand what they do. So SSRI targets just serotonin, whereas SNRI targets both serotonin and norepinephrine. SSRIs is a second generation antidepressant, which means what that means is it doesn't just act overall in the brain, but it's more of a targeted drug design. And so these are that's again in the name, they're very selective. So SSRIs are selective for SERT, the serotonin transporter, sorry. So again, what this does is serotonin, because it's not being transported back into the presynaptic cell, it's able to accumulate in the synapse, and therefore it's able to interact with the postsynaptic cell and activate the postsynaptic cell more. So you'll notice how all these drugs kind of have the same after effect of allowing neurotransmitters to stay in the synapse longer, therefore activating the postsynaptic cell more. Now, similar to SSRIs, SNRIs is again a second generation antidepressant, and these were actually created to kind of replace those TCAs, so those tricyclic antidepressants. The very first one was venlafaxine. This was in 1994. So this one is more, it's more selective to the SERT and NET, so the serotonin and norepinephrine transporters. And a great thing about SNRIs is that they do have a lot fewer side effects than the TCAs did, and you get an increased safety margin, so they're a lot safer, and therefore they're more widely used, and that's again why they've replaced those TCAs. So you'll notice that we had selective serotonin reuptake inhibitors, and then serotonin norepinephrine reuptake inhibitors, but we didn't really talk about selective norepinephrine reuptake inhibitors. And so norepinephrine reuptake inhibitors actually represent a third class of second generation antidepressants brought to the market. You guys might recognize the names Prolift or Endronax. That's what these ones are. So we probably won't talk about these ones quite as much, just because they're not in the market in the US or Canada. And there has been some question about the efficiency of these. They're reported the selectivity of 20 times for NET over serotonin, which is great. So again, it's gonna increase norepinephrine in the synapse, but not affect the amount of serotonin. But again, because they're not very common or used in the US or Canada, we probably won't talk about these too much, and you actually might not hear about them quite as much. So this image is just showing you the rank or how popular different drugs were kind of across the years. So on the x-axis for all of them, we have the rank. So the rank will be between 1 and 12. So out of 12 possible drugs, how were they ranked for kind of efficiency and how well they're used. So the solid purple line is efficiency, the dotted line is acceptability, and then on the right hand of your screen, you can see monthly prescription volumes, and it lists all the drugs. And it's showing you all these drugs, and in the year it's given, then that's actually the year that it was more like number one, or when it first came out. So, for instance, Prozac in kind of months in 2011, we got 2 million prescriptions in 2011. Here it says 1986, and that's when it first came out. But in 2011, then we had 2 million prescriptions a month about. And so, again, in this purple line, we're showing efficiency. So the rank of it is, more common on the lower end of the rank, but in terms of acceptability, it's very in the middle. So kind of people really accept it as, yeah, it works, but they're less likely to prescribe it. Whereas if we look at some of these other ones, so just right next door, the one that has 1994 there, the rank of fluvoxamine, then you can see how the efficiency and acceptability is kind of the same. So that's just kind of something fun to look at. And again, on the x-axis, then you have the common names, and then on the right side, those are the the company names. On the bottom here, then we have that selective norepinephrine reuptake inhibitor, and you can see how it's pretty low no matter what. It's pretty commonly hitting rank of 11 or 12, so it's not very popular, not very accepted. Okay, so let's do a fun systematic review. So in a more thorough systematic view than that last kind of graph thing I showed you, then about 74% of patient data from the original Pfizer trials was previously unpublished, which really means that you're not going to be seeing everything that's happening. They're kind of picking and choosing. So when you read, a research article from a drug company specifically, you're not getting the whole picture. So you want to be careful when reading papers that say are like, if someone's affiliation is with a drug company such as Pfizer or a big pharma company, you're going to want to, maybe question a bit these results might be great, but what are we not seeing? And so with reboxetine, which again was that selective norepinephrine reuptake inhibitor, it was actually found to be indistinguishable from the placebo, which means there was no difference from the placebo, so it wasn't having any effect as an antidepressant. They also found that there was significantly more adverse consequences. In other words, there were more harmful side effects. So the study's author actually concluded that overall it's an ineffective and potentially harmful antidepressant, and published evidence is affected by publication bias underlying the urgent need for mandatory publication of trial data. So in other words, this review that with the author I'm talking about pointed out that previous studies that were talking about how good the selective norepinephrine reuptake inhibitors were, they were from Pfizer. They didn't publish all the data, so how can we take that seriously? And again, this is something I want you guys to think about when you're doing your presentations on the papers. So now we want to talk a little bit about the placebo effect and antidepressants. So in all, antidepressants tend to have an efficiency of approximately 60%. So in published clinical trials, and remember a lot of clinical trials don't actually get published, but in the published ones, about 60% of patients in the drug group measured a 50% decrease in depression, which, is pretty good. But the placebo response, so participants that were given a placebo instead of the drug in trials, is typically between about 75 to 82% of the antidepressant effect. So in other words, between 40 and 50% of patients in the placebo also measured a 50% decrease in the depression scale. So, that's something we have to take into account. So 43% of antidepressant trials do show a significant benefit of drug over placebo. However, again, you have to keep in mind that about half of the trials go unpublished, and a lot of times it's because there's a negative result, so the drug companies don't want to publish that. It's also been suggested that antidepressants actually function as active placebos, which means they have noticeable side effects. So most patients in these trials can actually guess whether or not they're in the placebo group or the antidepressant group just based on whether or not they have these noticeable side effects. So that can also really affect your results. Now, so we talked about the monoamine hypothesis and the drugs that kind of support it and are used now as a way to treat depression. There are, of course, some challenges to this monoamine hypothesis. So one of the main challenges is really looking at kind of the differences between the pharmacological effects and the therapeutical effects. So pharmacologically, it can take hours or days to actually make a difference. So you can actually see a pretty big difference in the synapses themselves after taking these antidepressants. But you don't see the therapeutic effects or the behavioral effects for a couple weeks or months. And that's why a lot of times when people take drugs, their doctors will suggest you take it for about 3 weeks before deciding whether or not to go off of it or continue using it, so that you can see how the mood normalizes. And so because these monoamines normalize rapidly, but the mood normalizes slowly, some people question whether or not it's actually these monoamines that are responsible for the mood. So one thing we can really look at is that the efficiency of drugs that do not affect the reuptake of norepinephrine or serotonin. So, for instance, there's a drug, tianeptine. Again, I'm very sorry for my pronunciation, but pretty much what it is it's a serotonin reuptake enhancer. And so what that means is that it it helps remove serotonin from that synapse quicker or more. So it's removing more serotonin rather than what we've been talking about this whole lecture with the other antidepressants will make sure that there's more serotonin in the synapse. So it does an opposite thing pharmacologically. However, we actually see very similar therapeutic effects. So really what's happening there, So in these clinical trials, we see that they're equally effective at changing the mood over time as SSRIs. And then another question is when we talk about cocaine. So how cocaine works is it inhibits the reuptake of NA, which is, again, something that SNRIs do, right? But cocaine doesn't have an antidepressant effect. So what's happening there, So you would think that if cocaine does the same thing as SNRI, then it should have an antidepressant effect. Now, one thing here is cocaine, is affecting NA, so that's noradrenaline. If you're confused, NA is noradrenaline, which is another name for norepinephrine. So NA and E, same thing. So perhaps cocaine is acting as a selective norepinephrine reuptake inhibitor, which we just talked about isn't as effective as SSRIs or SNRIs. So maybe that's why, but again, it does challenge the monoamine hypothesis. And then, of course, there's also some inconsistent findings in antidepressant effects of amino acid precursors to serotonin and norepinephrine. So, if we increase the amount of tryptophan or tyrosine, then shouldn't that also help with antidepressant effects? But we don't see that. So instead, then there was a model was proposed retrospectively to explain the effects of MAOIs and TCA class drugs. So that's all we have here. On Monday, then we will go over some more information on depression.